second lecture now will be with second prominent speaker, Dr. Hatem Amin Attalla. Dr. Hatem Attalla is a professor of anesthesia and ICU Menofeyia University, and he's ex-chairman Department of Anesthesia and ICU Menofeyia University, as a consultant anesthetist and ICU in Alexandria Medical Center. And his lecture will be on the electrolyte imbalance. Because the last webinar he presented the first lecture on the electrolyte imbalance. All of us as anesthesiologists are involved in the perioperative management of patients with electrolyte imbalance that will affect the patient maybe intraoperatively or postoperatively. So all of us will be eager to listen to his wonderful lecture. Please, Dr. Attalla.
Thanks, Professor Dr. Adel. I'm going to share my screen. Okay, today we will continue our story about electrolyte disturbance. In the last lecture, we discussed sodium and calcium imbalance, and today we will discuss potassium, magnesium, and phosphorus imbalance. About potassium balance, we all know that potassium is mainly intracellular, about 150 milliequivalent per liter intracellular, and only intravascular compartment composed only 3.5 to 5.3 milliequivalent. So there is an intercompartmental shift or shift of the potassium from the intracellular space to the intravascular compartment. Potassium plays an important role in maintaining resting membrane potentials and generate action potentials in the heart and the CNS. The regulation of potassium either hormonal by three hormones: aldosterone, which increase sodium reabsorption and promote potassium excretion. Also, epinephrine and insulin shift potassium to the intracellular space. Also, the intrinsic renal mechanism, which regulate potassium excretion. The normal plasma potassium is 3.5 to 5 milliequivalent per liter. Hypokalemia means plasma potassium below 3.5 milliequivalent per liter. As regards the causes, either decreased intake or increased losses, or intercompartmental shift or redistribution of potassium into the cell. In redistribution of potassium into the cell may be due metabolic alkalosis, where increase the pH and low hydrogen ion. So hydrogen ion will be shifted outside the cell on exchange of potassium, which will enter into the cell and causes hypokalemia. Hormonal as insulin, beta-2 agonist or alpha antagonist. Also in anabolic state as vitamin B12, folic acid, total parenteral nutrition, and others as hypokalemic periodic paralysis, where they are attacks of paralysis alternating with hypokalemia and another attacks with hyperkalemia, where in this case also potassium will be shifted into the cell and causing hypokalemia. Hypothermia and in barium toxicity. Increased losses through the kidney in case of primary and secondary hyperaldosteronism, as aldosterone will promote or result in excessive potassium loss in the urine. Congenital adrenal hyperplasia and Cushing syndrome, where elevated glucocorticoid and cortisol also increase potassium loss in the urine. Renal tubular acidosis, diabetic ketoacidosis, the use of diuretics and other drugs as aminoglycoside, penicillin, and amphotericin B. All losses through the gastrointestinal tract, through vomiting, diarrhea, or gastrointestinal fistula, or through the skin in cases of burn and sweating, or decreased intake of potassium in starvation or clay ingestion, where some persons use clay for treatment of diarrhea or other stomach disorders. The clinical features of hypokalemia. The manifestation may vary between patients, either asymptomatic or appears the symptoms usually below 3 milliequivalent per liter. The manifestation will be neuromuscular and cardiovascular. The neuromuscular manifestation in the form of fatigue, myalgia, or muscle weakness. This may progress if severe to hypoventilation, also rhabdomyolysis and paralytic ileus. The cardiovascular changes is ECG changes, abnormal electrocardiogram, arrhythmias of any types may occur, orthostatic hypotension, decreased myocardial contractility, and expect potentiation of the digitalis toxicity. The ECG changes is the appearance of U wave, flattening or inversion of T wave, ST segment depression, prolonged QT, prolonged PR interval, widening of the QRS, and may proceed to ventricular arrhythmia. Here, the pattern is hypokalemia, where the appearance of the U wave gives a picture of biphasic T wave. Then depressed ST segment and wide QRS. The diagnosis, how to reach the diagnosis for the cause of hypokalemia, starting from the history. If there is losses through the gastrointestinal tract and vomiting, diarrhea, or through the skin, or through the kidney in the use of much diuretics, or hypoaldosteronism, then we assess urinary potassium excretion, assess potassium in urine. If it is low, below than 15 millimole per liter, and we assess the acid-base status. In metabolic acidosis, so it is a lower gastrointestinal losses in cases of diarrhea. If it is metabolic alkalosis, so it is an upper gastrointestinal losses, as in vomiting, also the use of diuretic or potassium loss through sweating. If potassium excretion is greater than 15 milliequivalent per day, we will assess potassium excretion through Trans-Tubular potassium gradient, which is the TTKG. The Trans-Tubular potassium gradient is to estimate the ratio of potassium in the lumen of the collecting duct to that in the peritubular capillaries. So it will reflect the conservation of potassium in the collecting duct of the kidney and can be measured through this equation, Trans-Tubular potassium gradient equal urine potassium over the plasma potassium divided by urine osmolality over plasma osmolality, and in normal diet it will be an 8 to 9. So here, if the TTKG greater than 4, we'll assess also the acid-base balance. If there is a metabolic acidosis, consider diabetic ketoacidosis or renal tubular acidosis, whether proximal or distal. If it is metabolic alkalosis associated with hypertension, so the cause is mineralocorticoid excess or hyperaldosteronism. If no hypertension, consider vomiting, diuretic abuse, or hypomagnesemia. Treatment of hypokalemia. First, to correct potassium deficit and to minimize ongoing losses. Also, prevent the life-threatening complications. The principle here is to use oral potassium because it is safer than intravenous potassium. But take in consideration there is no definite equation to correct hypokalemia because potassium is mainly intracellular. So any decrease in the intravascular value of potassium, it means after administration, it will shift it to correct the intracellular deficit at first before appearing in the values of the intravascular potassium. It means a decrease of about 1 millimole per liter in plasma potassium may represent a total body potassium deficit about 200 to 400 milliequivalent. So there is no definite equation to calculate the potassium deficit. Unlikely in sodium imbalance or sodium deficit, the sodium is mainly intravascular, about 135 to 145, and only a small amount intracellular, which is 10 milliequivalent. So there is a definite equation. We can calculate the sodium deficit and correct accordingly. Here, as a principle also, avoid dextrose containing solution. When to treat? When potassium 3.5 to 4, only increase the potassium containing food as banana, orange, and potatoes. If it is 3 to 3.5, only in high-risk patients, in patients with myocardial depression, hypotension, arrhythmia, we should start treatment. If below 3 milliequivalent per liter, we need definite treatment. As we said, oral potassium is safer. Potassium chloride is the preparation of choice. However, potassium bicarbonate and citrate can be used. In mild to moderate hypokalemia, we use potassium chloride orally, 60 to 80 milliequivalent per day in 3 to 4 divided doses. In severe or symptomatic, we give potassium 40 milliequivalent every 6 hours together with Ecg monitoring. And each 15 milli of the solution of potassium chloride contains 20 milliequivalent. IV potassium. We refer to IV potassium in severe symptomatic hypokalemia together with continuous Ecg monitoring. And as we said, we give potassium together with frequent potassium estimation to see if the patient needs more. Never give potassium chloride directly IV, as it may cause cardiac arrest. Rapid IV correction can cause dangerous hyperkalemia. Use isotonic saline and avoid dextrose-containing solution. The ampoule of potassium 10 milli contains 20 milli equivalent of potassium, and we give potassium infusion as cardiac rhythm return to normal, and with continuous Ecg monitoring, and then tapering the drip and refer to the oral potassium. If potassium given in the peripheral vein, it is very irritant and cause thrombophlebitis. So should not exceed 8 milliequivalent per hour if given peripherally, but in the central venous catheter, it can be given in a faster replacement and it does not exceed 20 to 30 milliequivalent per hour. In resistant cases of hypokalemia, you should consider hypomagnesemia. It may be the cause of resistant potassium to treatment. The anesthetic implication. Of course, any elective surgery, we should correct hypokalemia before surgery. In chronic hypokalemia, they are more susceptible for arrhythmia. Ecg monitoring is essential, preoperative, intraoperative, and postoperative. Avoid glucose-free solutions. Potentiate neuromuscular blockers is expected. Avoid alkalosis and hyperventilation avoided. Now we'll go for hyperkalemia. Hyperkalemia. It means plasma potassium greater than 5 milliequivalent per liter. The causes of hyperkalemia: either decreased renal excretion of potassium in case of renal failure, primary or secondary hypoaldosteronism, or the effect of drugs as spironolactone, non-steroidal anti-inflammatory, AC inhibitor, and heparin. Or due to extracellular movement of potassium from intracellular compartment to the intravascular compartment by the effect of acidosis, as we said, in increased hydrogen ion concentration in the intravascular compartment will exchange with potassium. It will enter inside the cell and potassium will come out the cell, causing hyperkalemia. In attacks of hyperkalemic periodic paralysis, the effect of drugs as succinylcholine in rhabdomyolysis, cell lysis following chemotherapy, digitalis overdosage, and cyclosporin also increased potassium intake. The clinical features of hyperkalemia, also skeletal and cardiovascular. The skeletal as weakness, flaccid paralysis, or hypoventilation. The cardiovascular manifestation, mainly Ecg changes, where increased T wave amplitude, or what is called peaked T wave, or hyperacute T wave, or with prolonged PR interval, if the potassium level between 6 to 7 milliequivalent per liter. Then widening of the QRS and the loss of P wave if potassium level is 7 to 8 milliequivalent per liter. Then sine wave pattern if potassium 8 to 9 milliequivalent per liter. Then ventricular fibrillation or asystole if potassium level above 9 milliequivalent per liter. Here, the Ecg pattern of hyperkalemia, tall T wave or peaked T wave, then prolongation of the PR interval and widening of the QRS. Here also, it appears as a peaked T wave, then loss of P wave and widening of the QRS with tall T wave, progressing to sine wave and then ventricular fibrillation. The diagnosis of hyperkalemia, we have to exclude pseudo-hyperkalemia or the shift of potassium to the intravascular space, exclude oliguric renal failure, stop non-steroidal anti-inflammatory drugs or AC inhibitors, which may be the cause of hyperkalemia, and then assess potassium secretion. Here also the TTKG, the trans-tubular potassium gradient, as we said before, and we show the formula where urine potassium over plasma potassium divided by urine osmolarity over plasma osmolarity, we can measure the trans-tubular potassium gradient. If it is below 5, see the response of fludrocortisone. Fludrocortisone, it is a corticosteroid which has a mineralocorticoid and glucocorticoid activity. If it is increased to above 10, so the cause will be hypoaldosteronism, whether primary or secondary. If the TTKG is below 10 and associated with hypotension and high renin, so the cause is pseudo-hypoaldosteronism and potassium sparing diuretic. If associated with hypertension and low renin aldosterone, so the cause will be cyclosporin and distal renal tubular acidosis. The treatment of hyperkalemia. The principle, we should start treatment if potassium is higher than 6 milliequivalent per liter in order to minimize membrane excitability, to shift the potassium into the cell and promote potassium loss. First, by calcium gluconate. Calcium gluconate in order to protect the myocardium from the toxicity of potassium. We use ampoules, 10 milli calcium gluconate given by infusion over 5 to 10 minutes under Ecg monitoring, and then it can be repeated according to the Ecg changes. Then insulin and glucose. Glucose insulin to promote shift of potassium intracellularly. We can use 10 to 20 units of regular insulin in 50 ml of 25 or 50% dextrose. Start initial bolus, then continuous infusion where its effect begins within 15 minutes and the peak effect within 60 minutes. Then sodium bicarbonate also help to shift potassium intracellularly by using 7.5%, 50 to 100 ml of sodium bicarbonate given slowly over 10 to 20 minutes. The beta-2 agonist as salbutamol given by inhalation also shift potassium intracellularly. The loop and thiazide diuretics in order to promote potassium excretion. The potassium exchange resins as sodium polystyrene sulfonate, which is powder given through the GIT, either orally or rectally, we promote exchange of sodium for potassium in the GIT, and it given in 100 ml for 3 to 4 times daily, and in resistant cases, hemodialysis. So remember, continuous ECG monitoring all over the period of management of hyperkalemia. The anesthetic implication, also ECG monitoring is very essential pre, intra, and post-operative. Succinylcholine should be avoided. Use potassium-free solutions. Avoid acidosis by maintaining mild hyperventilation. Also expect the dose of neuromuscular blockers will be potentiated, so the dose should be decreased. Then going to magnesium balance. Magnesium, the normal level is 1.7 to 2.5 milliequivalent per liter. 55% of this concentration is ionized and in active form. The magnesium also play an important role in regulation of sodium-potassium pump. Also, it regulates the function of parathormone and vitamin D, which will affect calcium metabolism, and control the potassium entry into the cell and potassium reabsorption by the renal tubules. Also, it has an effect on the vascular tone. It prevents vasospasm by maintaining the normal vascular tone by endogenous calcium antagonist effect. Hypomagnesemia, it means magnesium level below 1.7 milliequivalent per liter. The causes here is inadequate intake in food, reduced gastrointestinal absorption as malabsorption syndrome, short bowel, biliary fistula, severe diarrhea, Crohn's disease, prolonged nasogastric suctioning, or renal losses through diuretics and hyperparathyroidism, drugs as thiophyllin, diuretics, ethyl alcohol, aminoglycoside, and amphotericin B. The clinical features either asymptomatic or it may be associated with hypocalcemia and hypokalemia. There is anorexia, weakness and paresthesia, confusion, seizure, and up to coma. Atrial fibrillation may occur, potentiation of the digitalis toxicity, and prolongation of PR and QT interval. Here, as we see, hypomagnesemia is its manifestation usually due to hypocalcemia and hypokalemia. The treatment in asymptomatic, we can give oral magnesium sulfate 2 grams. In symptomatic, we refer to the IV route given by intravenous infusion over 10 minutes, magnesium sulfate 1 to 2 grams. 1 milli of 50% solution contains 4 milliequivalent. The anesthetic implications, there is no specific anesthetic interaction with hypomagnesemia, only take care of other electrolyte imbalance, which is the potassium and calcium, which are dangerous and affecting the ECG and the muscle. So any imbalance in potassium and calcium should be corrected pre-operative. Hypermagnesemia, it means magnesium level above 2.5 milliequivalent per liter. The causes here usually in patients with chronic kidney disease, excessive use of antacid or laxative, iatrogenic during treatment of preeclampsia as we use large doses of magnesium sulfate infusion, hypothyroidism, adrenal insufficiency as Addison disease, and the things to be monitored in hypermagnesemia is the tendon reflexes, respiratory rate, and urine output. Here there will be hyporeflexia, hypoventilation, and decreased respiratory rate, and decrease in the urine output below 50 ml per hour. The clinical features is hyporeflexia, drowsiness, and skeletal muscle weakness, hypotension, prolonged PR, and widening of QRS or respiratory arrest. So the treatment is calcium gluconate, IV given over 10 minutes. Also good hydration with half-strength saline and dextrose 5%, then loop diuretics, and in resistant cases, peritoneal or hemodialysis. Anesthetic consideration, usually monitoring the tender reflex respiratory rate and urine output to detect toxicity of magnesium. Expect potentiation of the negative inotropic effect of inhalation and intravenous agents and occurrence of hypotension and myocardial depression. Also, the dose of neuromuscular blockers should be decreased by 25 to 50%. As regards phosphorus, the normal level is 2.5 to 4.5 milligram per deciliter. The function of phosphorus is very important and forms the phospholipids, which is a component of cell membrane. Also, it is a component of nucleic acid and adenosine triphosphate as a source of energy. Enters in protein synthesis and acid-base balance, forming the phosphate buffer and structural support to the body. Hypophosphatemia, it means level of phosphorus below 2.5 milligram per deciliter. The causes here is malnutrition, decreased intake in case of anorexia and starvation, chronic alcoholism, severe burn, chronic diarrhea, or hyperparathyroidism, where there is excessive renal loss of phosphorus. Vitamin D deficiency, also resulting in low level of phosphorus in the blood. And during management of diabetic ketoacidosis, administration of insulin will increase uptake of phosphorus and shift it into the cell, also causing hypophosphatemia, acute alkalemia, and respiratory alkalosis. The clinical picture of hypophosphatemia is anxiety, fatigue, irritability, weakness, numbness, and joint stiffness. Also affect the breathing, irregular breathing, and it may be the cause of difficult weaning from mechanical ventilation. The treatment in severe and symptomatic hypophosphatemia, start IV infusion of phosphate ampoule over 12 hours and regular estimation of phosphorus level till maintaining normal phosphorus level. Then oral supplementation is required for 5 to 10 days. It is given cautiously to patients with hypokalcemia or renal failure, as it may accumulate and causing hyperphosphatemia. Hyperphosphatemia, the increased phosphorus level above 4.5 milligram per deciliter. The causes in patients with kidney disease or renal failure, hypoparathyroidism, the accompanying hypokalcemia, metabolic or respiratory acidosis. The signs and symptoms usually from the effect of hypocalcemia. There will be muscle cramps and tetany, perioral numbness, bone and joint pain, pruritus, and rashes. The treatment is to limit the food rich in phosphorus as milk, red meat, processed cheese, and preservatives. Decrease phosphorus absorption from the intestine by using calcium carbonate or calcium acetate orally. Dialysis for renal failure and to remove excess phosphorus. Thank you.
Thank you, Dr. Attalla, for this wonderful lecture. I can see now a lot of interaction, the questions from all the attendees. And I would like to first start with Dr. Walid to answer these questions. We have a question with Walid here.
Yes, Amir.
Yeah. First one about the additive to the tab block. It mentioned dexamethasone, but from my side I can ask other additives like Perspex or ephedrine are mentioned here in the questions. But I can ask what about epinephrine or other additives to prolong the effect of tab block. This is the first question.
Okay. So thank you very much for that question. So most of the studies show that the dexamethasone can be added to the tab block. Other additives, there is colidine has been used. I see some articles there, but this will increase the duration of the block maximal to the 18 hours. I never see anybody who's describing that TAP blocks will exceed than 18 hours. So if you don't give anything, usually around 12 hours, if you put additive, it will be reached to the 18 hours. So 18 hours is still less than the intrathecal morphine if you have the availability to have a patient monitored for respiratory pressure for 24 hours. So if you have, even if you have additive, if you have the possibility to have patient monitors, it's better intrathecal morphine. If not, you can add dexamethasone 4 milligram each side. It will increase the duration of the block till 18 hours.
Okay. Do you have an experience of adding like Brisdex with either with TAP or
Colonidine before? We don't have Brisdex, but colonidine has been added before, but still all this does not increase the block too much. It's a few hours only.
Yeah. As you said, from my experience in our hospital, if we add the Brisdex or colonidine to the QLB, already QLB is prolonged. So the difference will not be so much because already, as you said, mentioned in the lecture, the QLB is longer duration, more than 24 hours. Other question talk about concentration. I think you answered this one, but you can quickly elaborate the duration and the concentration.
Yeah, so this is a facial blend block. You have to give a high volume. So to have an effective block, you have a high volume. If you want to give a high volume, you cannot give a high concentration because you reach easily to the toxic dose. So you have to dilute the concentration. Our concentration is 0.125%. So you can easily give 50 or 60 ml total, 30 each side. It will be easily reached. Even some people use 40 ml if you calculate it as a 0.4. But if you use 0.25%, still your volume will be less. You cannot give a high volume. The spread, depending on the volume, that spread higher to the higher levels at the T5 or T6. You cannot do this with a small volume. It's a facial blend block. It needs a higher volume. So higher volume means lower concentration.
Very good. Because there is some questions about the effectiveness, and I think, as you said, the better the spread, the better the response. Do you agree with that? This is one of the factors that affect the effectiveness of the block.
Yeah, of course, if you have more dermatomal symptoms, you have a more successful block. This is understandable. TAB or QLB or whatever, ESP, any blocks that you have, if you have more spread, because you are not blocking a certain nerve, you are putting the nerve ending. So if you have more nerve ending blocks, you have more spread, more successful block.
Okay. To conclude this point, is it effective only for visceral pain regarding the QLB or the visceral pain?
Visceral or?
Visceral or somatic pain?
No, so the QLB work for both because the mechanism of action is working through the diffuse through the fascia. Fascia has a lot of sympathetic nerve endings, so it works for both. But TAP block is only somatic because it works for the superficial nerves only. So TAP block will not cover. And if you have a midline block, still you need also you put a rectus because there is 3 different plexuses here in the anterior abdominal wall. You have to block each plexus separately. So you have to give upper, lower, and rectus block to have a complete anterior abdominal wall, but nothing to do with somatic visceral pain because you are not blocking sympathetic. Sympathetic, you have to go more posterior towards the sympathetic plexus.
Okay, we have a question from Dr. Talat here. What about the QLB and open nephrectomy?
Yes, it's work for any. So QLB has been used for many procedures. Almost any intra-abdominal procedure have been used, and nephrectomy is one of them. It's also used for hip surgery. It's used for back surgery. We are using for chronic pain very commonly, and it works for definitely for nephrectomy and open nephrectomy. It's open, definitely works.
This is very good because from our experience also in our hospital, any operation from the symptoms to the sternum, you can get QLB, and you are.
Yes, I totally agree. From my point of view, there is no place for TAP anymore. If you know how to do QLB, it is the way to go. If you don't, you can do TAP. But if you know how to do QLB is much better.
Another question from Dr. Hani. He is talking about the QLB and paravertebral. You know about the debate about the effectiveness and the risk associated with both of them. Can you elaborate and extend this one to the epidural? QLB, paravertebral, and epidural.
So, of course, if you go more central, you are blocking more nerve. But if you go more central, you have more complications. So the reason of moving peripherally is to have less complications. And the end result of QLB is going through the paravertebral space. There's many articles comparing paravertebral space and epidural and the QLB, and most of them says there is no difference. So if there is no difference in the outcome, why should do a blocks? QLB is single injection. Paravertebral is multiple injections, and you have higher risk for complications. So why I should do something which give me high risk, take a longer time if I can do something easier and less time consuming, and I have the same result.
Okay. Do you have a comment regarding you can do QLB only as a sole anesthetic agent for like abdominal hernia, umbilical hernia?
Means the soul that this is an analgesic block. This is not an anesthetic blocks.
Yes.
It's all analgesic blocks. It's not anesthetic blocks.
Yes. Yes. For our clinic, we have we recommend use linear probe or curvilinear probe, especially if you have difficult patient and you cannot visualize the QLB well.
So QLB, even in thin patients, you need a curvilinear probe. This is a deep block. This is a posterior block. You have to use a curvilinear probe. You're not able to see well with high frequency probe. You will see the muscles, but you will not see the fascia. You will not see your view. You will not see all what structure around you you need to see. How can you see the transverse process, which is around 8 to 7 centimeters with high frequency probe? It's not possible. So any posterior abdominal wall blocks is all, even thin patient, all low frequency probe. Any anterior abdominal wall blocks, you can use high frequency probe.
Okay, another question, is there any potential lower limb weakness or block with the transmuscular QLB compared to other blocks?
Yes, because yes, it's definitely there. Lumbar plexus, you are blocking the femoral, and there is spread to the epidural space and spinal space, and there is leg weakness, and some lecture reported foot drops also. So
but with which one? With which one, please? Because some
with the transmuscular, because the tequila block. Transmuscular is the tequila block, and they call it tequila. It's related to a kind of wine. Yeah. That means very strong. Okay. Yeah. And this word coming from, it's a Russian word, but it's coming from people who from Denmark. They call it a tequila block. Means it's very strong, like a Russian tequila. Okay. So transmuscular, because you are blocking that, you are definitely some. Even if you are in 100% sure that you are in the plane, there is some of the, with this big volume, will leak to the psoas. And it leaks to the psoas, it will block the femoral, block the lumbar plexus, and it blocks the femoral, and it will spread to the epidural space, and it will lead to the leg weakness. And before another center I was working, we have every day, almost every day, because they are using a transmuscular approach in Toronto. Every day we have one, we are doing 20, 30 a day. Every day we have one patient who cannot go home because of leg weakness.
Okay, I know your practice that you are giving spinal followed by QLB.
Sure.
Yeah, so there is a question here about the tab block or QLB before delivery, after delivery.
Okay. We cannot do it before delivery because you will not be able to see anything. The baby and the uterus taking everything, you cannot see anything. We tried this before, we are not successful. We cannot do it, we cannot see. The same after general anesthesia, if they inflate the gas, we cannot see anything. So you have to do it after delivery of the baby. So you have a room for yourself, you are confident, and the surgeon also is not afraid about the patient, because if you put your scope, put your ultrasound there, I'll try to find the muscle. All muscle are compressed. You cannot have a good picture of the muscle. So after delivery of the baby, for 100% sure.
Yeah, but other surgeries, like I'm doing general surgery, usually, so I do.
Yeah, you don't need to worry. You can do it anytime. But here we have a special situation that we have a baby inside.
Okay. Thank you very much, Dr. Walid,
Thank you.
for this wonderful answer and lecture tonight, and all the best.
Thank you very much.
We can start now with the question for Dr. Hatem Attalla. There is a question here, Dr. Hatem. Will you ask now, Dr. Hatem?
Yes.
Attalla? Yeah.
Okay.
The first question now talking about the when you stop elective surgery if you have a patient with hypokalemia. Postpone surgery.
Postpone.
Postpone surgery.
Yeah.
Yeah.
In elective surgery.
Elective surgery.
Elective surgery, we should postpone it until correction of hypokalemia. Even it is below than 3, especially in a high-risk patient with ECG abnormality, arrhythmia, or hypotension. This patient should be corrected before surgery, and the surgery should be postponed.
Whatever is chronic or acute?
Hypokalemia?
Yeah.
Whatever the cause.
Okay.
If it is, especially if it is acute. But in chronic also, if it is correctable, it should be corrected before surgery.
Okay. There is a rule here. There is a question about the rule of bicarbonate and treatment for hyperkalemia. But I want you please to elaborate more about the effectiveness and of the measures to lower the potassium and to treat hyperkalemia. I mean, like sodium exchange, resin, or bicarbonate. Which one acts first? Which one has to take time? Should I start with potassium exchange resin in a case of hyperkalemia, or start with bicarbonate, or to start with glucose insulin infusion? Because if you start please.
First, we start with calcium gluconate in order to protect the myocardium once potassium is above 6 milliequivalent. Then, at the same time, start glucose insulin in order to shift the potassium intracellularly and help in reducing the potassium level. Then use sodium bicarbonate, IV, and diuretics, and beta-2 agonist. Then, if these measures fail, we can resort to the sodium resin, potassium exchange resin.
Okay.
And at last, hemodialysis, of course.
Hemodialysis, yes. Hemodialysis. So the action of some of these drugs is short-lived and it will not for a long time. So you start with it and you continue with long-acting one.
Yeah.
Am I right?
Yes.
Yes.
And the role for sodium bicarbonate here, either shift the potassium intracellularly, or if there is an acidosis, it can correct the acidosis and help in correction of hyperkalemia.
Okay, can I extend this question about if you talk about the acidosis? What is the acid-base disturbance that affects the potassium? I know this simple question, but for other colleagues, the juniors, what is the
either acidosis or alkalosis.
Yeah.
Alkalosis result in hypokalemia or hypokalemic alkalosis, while acidosis result in hyperkalemia.
Okay. Now I think there's one other question talking about when to give calcium. When to give exactly? I don't know what.
As we
exactly.
said from the start, to protect the myocardium. Once potassium level is elevated above 6, we should give calcium from the start.
Yeah, from the start. Yeah, don't wait until you. Okay.
No.
There's a question about the concentration here. Sodium bicarbonate mentioned 7.5 in difference to 4.8 concentration.
No, the available sodium bicarbonate concentration 7.5, so it can be given.
Okay. How to calculate the TTG intraoperative? Because you
No,
know
it is not used for intraoperative use.
Thank you.
We should correct hypokalemia or hyperkalemia preoperative and continue the measure if needed intraoperative. But the TTKG is used in the ICU only to reach the diagnosis or the cause of hypokalemia or hyperkalemia by measuring the urinary potassium and plasma potassium and the urine osmolarity and plasma osmolarity. So it is a clue or a key to reach the diagnosis or the cause of hypokalemia or hyperkalemia.
Okay. There's another question I want to ask from to other colleagues, to our juniors. What is the role of magnesium in correcting the hypokalemia?
Magnesium control potassium entry to the cell and increase potassium reabsorption by the renal tubule. So in case of hypomagnesemia, there will be a resistant hypokalemia. If we manage hypokalemia and see that the response is not good, we should estimate magnesium level, and hypomagnesemia may be the cause of this resistant hypokalemia and should be corrected to help in correction of potassium.
So resistant hypokalemia means we think immediately about hypomagnesemia and associated hypomagnesemia. Yes.
Yes.
Thank you very much for all of our attendees. Thank you very much, Dr. Walid, Dr. Attalla, for this wonderful lecture.
Thank you.
We hope, inshallah, we meet very soon again. The mic with you, Dr.
Hisham. Dr. Hisham. Is Dr. Hisham here? I would like to thank you, Rachel, for coming here tonight, and I believe it is great and wonderful webinar. I'm happy to see Dr. Adil as a moderator, really a model by example, you know, and I'm very happy to see my great colleagues, Dr. Walid and Dr. Prof Hatem. They are my senior, older than me, guys, all right? Dr. Hisham?
Yes, Prof.
Yeah, go ahead. Thank you.
Yeah. So I would like to thank every one of the panelists, every one of the attendees. I hope you enjoyed today. And I would like again to thank the organizing committee for the great efforts done for this work to be as the way you see it today. Thank you, everyone, and see you in the next session in the Mega Online course.
Dr. Huda Fawzi wants to talk.
No, I just want to thank everybody. The lecturers for today, the lecturers for the previous lectures, you managing the course. It's really beneficial. Thank you all, and thank for the attendees for their presence.
Thank you. Thank you very much, all panelists and attendees tonight, and all speakers, and Dr. Adil, and thank you very much. And we have to close now. Thank you. Thank you.
Thank you all.
Thank you.
Bye.